Good afternoon. Welcome to Medical Grand Rounds. We're virtual only today, and I am thrilled to have my dear friend and our special guest, Dr. Ashish Jha, with us today. Since most of the people viewing this live in California, you probably have not seen any advertisements. You may not realize there's a presidential campaign going on, but for the rest of the country, it's people are being inundated. And although health policy has not been issue number one in the debates and in the discussions, it obviously is profoundly important to the country. And whoever wins both the presidency as well as Congress and down ballot races will have profound implications on health and health care. And there really is no one in the country better situated to discuss the health policy implications of the election, and sort of we'll move and talk about some of the big issues that may not be decided by the election, but really are major health policy issues that we're all thinking about. Then Ashish Jha, as I think you know, is currently the dean of the Brown University School of Public Health. Prior to that, he served as the White House COVID-19 coordinator in 2022 to 23. Prior to that, he was director of Harvard's Global Health Institute. During COVID, he became internationally known as an incredibly thoughtful and trusted spokesperson and source of information on Twitter and in the national and international media. What you may not know about him is prior to that, his career has been really immersed in the world of health policy, and he is one of, if not the most cited, researcher in the area of evidence-based health policy in the country. Probably most importantly, he was a resident and chief resident in internal medicine at UCSF in the late 90s and I think up till about 2000. And we still take great credit for all of his accomplishments. So in today's talk, we will sort of cover some of the key issues in health policy. And before we start, Ashish, first of all, welcome. And second of all, I think you have a few little caveats to give or disclosures around your relationship with the administration.
Sure. And Bob, first of all, thanks for having me back. It's one of my very, very favorite things to do. I too give UCSF all the credit and sometimes the blame for things I have done in my life, but it was certainly the 5 years I was at UCSF, I would say, are from a clinical and even policy thinking the most seminal years of my career. So it's incredibly meaningful to come back. Yeah, in terms of disclosures, I just want to say very upfront, we're going to talk about health policy, I think, more broadly. And I obviously work in the Biden-Harris White House. I got to know both President Biden and Vice President Harris reasonably well. And then more recently, I've had no formal role with the Harris campaign, but I've had conversations with them. I've done doing a call, for instance, with Doctors for Harris. They invited me to just come talk about health policy in the election, a version of the discussion we're going to have today, which I agreed to do. So no formal relationship, but I think people should just ought to know that I've had some informal discussions, and I will obviously try my best to be thoughtful about my analysis here, but better to disclose the biases we all come to these conversations with.
Perfect. All right, so why don't we start with the fun stuff? Tell us about Kamala Harris from your interactions with her.
Yeah, I'm a huge fan. And I will tell you, my interactions with her, officially briefed her, I think, only once, did lots of unofficial conversations. What I mean by that is, I'd hear from her team that she wanted a quick update on something, or I would run into her in the hallways, and she would pull me aside and ask me a question. My experience with her, and then I'll talk a little bit on the personal side in a second, but just from a much more, professional, she was super kind of engaged on topics. I found her very substantive. She asked really hard questions, and to me, that's what you want from a principal, is someone who is really engaged. One personal story is she had a holiday party she does every year at the vice president's residence, and so we all get a +1. So I invited my then 11-year-old son as my +1. And we were in line. We got up to talk to her and to the second gentleman, and she saw my son. She stopped everything, kind of knelt down, ended up having this 5-minute conversation with him. Wow. Doug and I looked at each other like, okay, we're the superfluous, not really useful people here. And she's just sort of incredibly warm and delightful. And so, yes, substantively, very strong. But on a personal level, my interactions with her, at least, and my son's one interaction with her was extremely warm. So I'm very excited. Again, personal disclosure, I'm excited that she's the Democratic nominee.
Great. One more, maybe slightly tougher question. You had obviously a lot of interactions with President Biden. What did you see in terms of his performance and abilities during your time with him?
Yeah, so my last substantive interactions with him were probably in May of 23. I left in June, so maybe May or early June. I had a personal interactions with him when my wife and my parents and my kids went to visit with him in the Oval Office in August. My interactions with him were largely in the middle of the day, in very much around policy issues. And I will be very frank about this. Like, I found him very effective, very engaged. There were times we would send in a memo to the president on a topic where we all tended to agree that this was the right answer, but we just wanted his blessing. I'd get a call from the Oval Office. The president wants to talk about it. I'd go in, and he would often disagree with the assessment of his senior team, and he'd say, "No, I don't know that that's what we're going to do," and had generally very good arguments. So I appreciate the concerns that have been raised about him. Again, I have not interacted with him personally in a while, a little over a year. But my personal interactions with him were very substantive, and I didn't really see anything that made me suggest that he was not quite as engaged and effective as some of the stories certainly talk about.
Yeah. What'd you think when you watched that first debate?
It was a bit shocking. It was not the Joe Biden I had interacted with, and it was very concerning. And of course, the questions were like, has he gotten worse in the last year since I saw him? That's possible. We all know older people can decline quickly. Was there something else happening? I mean, there was talks about, maybe it was some medicine he took. We also know that a lot of cold medicines, other things can cause people to get confused. He was not the Joe Biden I had known for the year and a half or so that I had interacted with him on a pretty regular basis. So I would say I was pretty shocked. I think a lot of people were.
All right, let's move on to health policy. We've passed the view segment of our chat together. Let's start with COVID, and then we'll move on to other things. Sort of, how do you view the current state of COVID, and then maybe broaden it to what some of the lessons that you took from our response to COVID going forward?
Yeah, yeah. So the current state of COVID is, in my view, we often say, and this was a line I use a lot at the White House, but I think it's worth like taking a step back on this. We often say, well, we're in a much better place. Well, of course, we're in a much better place. We have a lot of immunity, and the virus just is not causing the level of disruption. I think having a realistic understanding of where we are with COVID is important, though, because the way I look at it is, look, from day one, people have tried to compare it to the flu. So let's just talk about COVID versus flu, and then kind of how to think about this moving forward. Typically, 10 to 15% of people get infected with flu. Flu mortality rate is probably about 0.1%. I think COVID's mortality rate is lower than that, probably half of what it is for flu. But best assessment, probably 50-70% of Americans are going to get infected every year with COVID. So attack rate is sort of 5 to 7 at a population level. And that means a lot more people are going to die of COVID than flu every year. And that is a pattern that I don't see changing anytime soon unless something specific happens. We make substantial improvements in indoor air quality. I think that can reduce transmissions. I think we get a better vaccine that really blocks transmission, reduces infection. That can make a difference. Otherwise, we're kind of in this for the long run. Nothing about the virus makes me think that it's going to stop evolving. It's going to continue doing what it's doing. And then the vaccines are very effective at preventing serious illness and death among high-risk people, but they're not particularly good at preventing infection. And so we have this very high level of a new disease that's pretty disruptive. And last point maybe on this is that I do think we've settled into a pattern where we tend to see about 2 waves a year, a summer wave and a winter wave bigger than the summer. They come, and I look at this as, no, it's not like awful, but it remains a pretty disruptive virus, and we should be doing more to get that under control. 70% of the population getting infected every year, 60%, that's just not a great number that we should just resign ourselves to.
Mm-hmm. It feels like the COVID narrative during this campaign is that, at least one half of the country thinks that we overreacted. My sense is there's a lot of forgetfulness that 1 million people died or more. But as you do the sort of post playbook on how we did, and obviously we've got to think about maybe there will be a next one. What's your self-assessment? I don't mean self-assessment of your own performance, but self-assessment of the U.S. performance and what we got right and didn't get right.
Yeah. And by the way, I have been thinking about my own self-performance as well. I mean, no doubt that I myself got a bunch of stuff wrong. But I think if you think about kind of where we were, look, I guess what I would say, Bob, is at a high level, if I always sort of remind people the whole point of a pandemic, the reason pandemics happen is you have a virus, a novel virus in a immune naive population. And until you can build up immunity, ideally with a vaccine, you want to manage the virus much more aggressively. In 2020, I would say we did not do a great job of that. And the best way to do it, the least disruptive way, is to have really good surveillance, really good testing. And we really did not get testing figured out for much of 2020. I think the reactions early in 2020 of a very aggressive effort to try to curtail the virus made sense, given that you were seeing body bags and frozen trucks outside of Elmhurst Hospital and elsewhere. There were things that I think we got wrong. I will tell you one of my things that I think I was too cautious on schools. In July and August of 2020, I thought it'd be really dangerous to open schools. I would say by the end of September, it was clear we could open schools and do it reasonably safely. I switched, but my community, lots of other communities, didn't really open up schools until next spring or even next summer. That to me was ridiculous. One of the lessons is it's fine to not get it right initially. It's much more of a problem to not pivot when the data comes in saying your initial assessment was not right. That has been a problem that has plagued I think the country throughout. Where do I think overall the country got? I mean, again, I think the other part where we have really struggled is getting vaccine numbers as high as they needed to be. Our death numbers in 21 and 22 were much higher than they needed to be because a large proportion of high-risk people never really got vaccinated, didn't get both doses. The anti-vaccine sentiment that grew, I think, was very harmful. Maybe the last point I'll make on this is it's interesting to watch UK, other places doing a deep dive into and a real inquiry. There's been a lot of calls for a 9/11 style commission. I don't think there's any appetite for it in the United States. And I don't think there's any appetite for it across the political spectrum. And so I worry a lot that like without that kind of careful examination, we're not going to learn all the lessons that we need to. I think there's things that we clearly could do better next time. And I think we've got to figure out how to get those things implemented without a deep inquiry into what went right and wrong.
I think one other issue that seems to be coming up a lot now is how do you calibrate the response to the next one? It reminds me of hurricanes, that when you've had a bad one, the next one coming through, people may, their reaction is going to be tempered by the last one. In the last year or two, there have been several, is this going to be another big pandemic threat? And I'm not sure we figured out how to calibrate that. Everything is, so tempered by or conditioned by COVID. How do you think we're doing on calibrating our response to to emerging threats?
Yeah. It's a good question. So we've seen new things, right? Like we've seen H5N1 among dairy cows, which we never saw before, and some spillover into humans. We've seen Mpox kind of reemerge in the last couple of years. Obviously, we're seeing Marburg, and so in many ways, I think that people are just on some chunk of people are on much higher alert and just tend to be a bit more reactive. I think overall the policy response on those specific viruses have been pretty appropriate. I don't think, there's always going to be people who are going to try to kind of create a lot of fear. I think they've been pretty appropriate. What I worry about is, let's take H5N1. So far, it has really not, we've seen no evidence of human-to-human spread. It has largely been pretty mild in the people who've gotten it. But we all know enough about this virus to know it could get meaningfully worse. What I worry about is, do we have the systems in place to know when we've got to raise the alarm? How do we do it in a way that doesn't feel like we're crying wolf again? And how do we get people to take any response to it seriously? And those are really important issues that I think require all of us in public health and political leadership to think through a lot more effectively, because we are going to have one where we're going to have to do some difficult things. Hopefully not the kind of restrictions we had to do with COVID, but we're going to have to respond and vaccinate and build up testing and do all the things that we know can also make a big difference.
you mentioned, maybe my last pandemic question, we'll move on. You mentioned that one of the saddest things that happened was vaccine disinformation, misinformation, and that many, many thousands of people died unnecessarily because of relatively low vaccine rates. I think that's right. I'm still kind of at a loss as to what we would do the next time that would be different. It just feels like some of these are so baked into a world where everyone sort of chooses their own information adventure, where an incredibly partisan political environment, where, if anything, the ability to do misinformation has gotten now turbocharged by deep fakes.
Yeah.
So clearly that was a problem. Do you have any insights as to how we might do better the next time?
Yeah. So a couple of thoughts on this. First, I think it is absolutely right that all of us live in our own information ecosystems. And everybody believes, it's just funny, I give a lot of talks on this topic. Everybody believes that everybody else lives in a bubble. And they're like, I get access to the facts, but everybody else lives in a bubble. It turns out everybody lives in a bubble.
Right.
And it's very hard not to live in a bubble. And all the algorithms of social media and everything else drive us towards more of that. So that is a fundamental problem. And I think the pandemic has made that worse. And I think it has created distrust across organizations and institutions that are really harmful. I think the way you solve this, and again, there's nothing easy about this, is through more relationship building and trust building. And that's just going to take time. So I think like one of the things that we need to do more of, so I'll give you one small example on this. We hired at the Brown School of Public Health the guy who was the former Surgeon General of Florida for the first year and a half of the pandemic under Governor DeSantis. And part of the reason he's great, part of the reason is I need to train our students to be able to go work in purple and red states, not just in blue states. We need to have more people understand the perspectives of Americans with whom we don't agree. I think public health needs to do more bridge building with religious organizations. I think there are a lot of religious organizations that feel particularly burned by public health because of the way we talked about churches being super spreader places. Like churches are sacred to a lot of Americans. And I don't know that the public health community did a great job of managing that. So there is a lot of repair work to be done. You're always going to have people who are going to exploit those divisions. I don't know what to do about that. But there's certainly a lot more we can do inside public health to build relationships. And then if and or when we get that next challenge, we're going to have to depend on those relationships to overcome bad information.
Right. I have a feeling half of our listeners are now searching which Florida Surgeon General you hired, because I can think of some.
The former one.
The former one. Okay, thanks.
Scott Rivkees. Yes.
Thank you. Perfect.
Dr. Scott Rivkees. Scott is great.
Good.
And, and he was very effective. And he worked very closely with Governor DeSantis and did a very good job. And he's got a lot to teach our students.
Great. Great. All right, let's move on to sort of, in some ways, more traditional health policy issues. Give me your sense of the state of the ACA and what might happen if one party or the other wins.
Yeah. It's a big question because obviously ACA is a very complicated law and a lot has happened. So at a high level, I mean, if you think about like what the ACA accomplished, about 50 million Americans didn't have health insurance, cut that in about half, bounces around, et cetera. A lot of that was the 40 states that have expanded Medicaid. There are 10 states that have not. And, I think there's going to be more, if we have a Harris administration, I think there's going to be more pressure on those states to expand. If there isn't, there's going to be less pressure. I don't know how responsive those states are going to be. There's been a lot of pressure for a long time. They have not really moved. I can't imagine one or two states moving, but I don't, Mississippi, Wisconsin, maybe, but you're still going to have some number of states that are not going to. The IRA, the Inflation Reduction Act, put in enhanced subsidies for people to join private plans, ACA plans. By the way, if you look at the states that have been the biggest beneficiaries, where have people signed up the most? It's largely Florida, Louisiana, Alabama, Georgia. It's much more the southern states where people have signed up in record numbers. I remind people, 1 in 4 people in Miami-Dade County. I'm sorry, Miami-Dade are on an ACA plan. So it is the beneficiaries have largely been Republican states. The Harris campaign has been clear that they want to extend and make permanent those subsidies. We haven't heard much from the Trump's team on that. But my guess would be that if they really do want to repeal the IRA, which they say they will, then those subsidies will go away. Maybe the bigger picture point here, and it's interesting. So J.D. Vance, the vice presidential nominee, obviously on the Republican side, has talked about high-risk pools and putting people into high-risk pools. And I think the way to think about this, in my mind, there's a conceptual issue of how this will all play out, and then kind of the policy issue. The policy framework for the ACA was the idea that we should get rid of discrimination or charging people based on pre-existing conditions and essentially create a pool where the healthy end up supporting the sick, and that everybody's kind of part of that one bigger pool. That protection against pre-existing conditions, I think the Vance idea wants to do away with and put people who are at elevated risk into high-risk pools. It technically could work. You'd need a lot of money to make that work because high-risk people are, by definition, expensive. I have not seen any evidence that that's actually going to be carried out. So I think repeal and replace is out on the Republican side because I don't think they have a replacement plan. But I do think you're going to see substantial tweaks to the ACA in a way that will almost surely lead to a lot more people being uninsured under a Trump administration. That's not just sort of conjecture. We saw uninsured rates go up every year during the Trump administration. And my guess is a lot of stuff is going to get implemented that's going to drive those uninsured rates up under a Trump plan. And maybe I'll make one last point on this. You know, the ACA is very complicated, and so much of it is about implementation. So much of it is left at the discretion of the Secretary HHS. Democrats believe in the ACA, so they try to do a good job of implementation. Republicans generally don't believe in the ACA. It is hard to get someone to implement something well that you don't believe in. Mm-hmm. So I think even if you have good people in that role, the implementation is always going to be, lacking. And I think we're going to see a real increase in the uninsured rate under a Trump administration. That's something we saw last time around, and that's how I suspect this will play out.
One of the things the ACA was designed to try to do, at least, was get a handle on healthcare inflation, not just cover more people. And the argument has been made that it didn't do that as well as one might have hoped. Yep. First of all, what's your take on that? And second of all, what do you see the prospects being to get a handle on healthcare inflation, particularly as we look at some of these massively expensive drugs coming out?
Yeah. So I think the critique that the ACA did not lead to a lot more affordable care is largely right. I don't think we've seen, a huge bending of the cost curve. Now, the supporters of the ACA will point out that Medicare spending per beneficiary really did flatten out. And there's a lot of speculation on what has caused that. But overall, healthcare spending has continued. And we can talk about what the counterfactual would have been in a world without the ACA. I think it's probably helped some. It has not helped a lot. Part of what the ACA banked on was delivery reform, payment reform leading to delivery reform, ACOs, alternative payment models. They have gotten some traction. They have not taken over the world. Real risk-based contracts with ACOs and two-sided risk probably still represents 30% of care inside Medicare. So it's not, and private insurance. So it is not like that experiment has failed. It just hasn't really been fully implemented. So if you're a true believer in those, you say, we won't know until we get to 60, 70, 80%. Other people say, it hasn't had the kind of impact.
Let me just actually, are you a true believer in that? Are you a believer that if we got the right payment reform and value-based payment, that it really would improve quality and lower costs?
I think it certainly can improve quality. I think there's pretty good reasons to believe it will. It does. Cost is harder, and cost is, of course, made up of two separate things, right? It's made up of a combination of price and quantity. Maybe it makes a difference on the margins on quantity. Prices are fixed, and in the Medicare program and in the private sector, prices have generally been going up because of consolidation. So I think payment reform, delivery reform unto itself is absolutely not going to be enough. It maybe is one part of the puzzle. I do think it's one part of the puzzle, by the way. I mean, certainly better than the fee-for-service system we had, but we've got to deal with consolidation. We've got to deal with market power. And that means more aggressively enforcing antitrust laws. It means more transparency in the system. And then I actually think some of it is going to come from more innovative new care models that come in and disrupt, because there are very few industries that just wake up one morning and say, we're going to reform ourselves and we're just going to become lower costs. They become lower costs because there's someone out there with a higher quality or lower cost product that if they don't reform, they're going to go out of business. We need to see more of those entries into the marketplace.
So in terms, you mentioned consolidation being a force for raising prices. I assume kind of because of an anti-competitive environment that you have a market leader who can set their prices and hold on to them. So will the administrations differ in terms of their willingness to take on consolidation?
So
Yeah,
that's a great question. The FTC has been very active under the Biden administration. Lina Khan and the FTC have been going. I mean, they went after PBMs. They've gone obviously after lots of people outside of healthcare, and they've been pretty aggressive on healthcare consolidation as well. I think we saw some of that happening under the last couple of years of the Trump administration, but nothing like what we've seen. Obviously, we don't know whether a President Harris reappoints a Lina Khan or someone like that. We don't have much signal from the Trump administration about what a President Trump would do. All else held equal, I would say, yeah, probably more aggressive FTC under a Harris administration than the Trump administration, but that's conjecture based on several facts like what has happened over the last 4 years. But I think the issue of healthcare consolidation is something that is appreciated across the political spectrum. Whether you're willing to use the arm of the Federal Trade Commission and the existing laws to do something about it or not, that part is less clear.
And I know you've done some of the foundational research on what happens when there's consolidation of health systems. Is that a slam dunk? I'm thinking about us at UCSF Health, that we now are just bought 2 failing hospitals in San Francisco, in part because we have more patients that want beds at UCSF than we have beds for. The hospitals were running 30% full. We're losing a ton of money. It seems like the quality of care should go up when we go in and UCSF eyes these institutions. You could argue that maybe costs could go down, although obviously there's a counter argument to that. So how strong is that evidence base? And when we talk about, because it does feel like it's almost become orthodoxy that consolidation does not lead to sort of anything good in the healthcare marketplace. It's something to be fought.
I don't view this being so monolithic, and I think that's not where the evidence is either. I mean, there are studies that show that there are instances where you've had consolidation or one health system purchasing another and quality got better. That clearly can happen. I guess what I have always said is you can't take a blanket approach on these things. You got to look at it on a case-by-case basis, fact-by-fact basis. I think we have to be honest that there are a lot of times where the motivation of health systems joining up is market power. Mm-hmm. And some of this is like I worked on an FTC case about 5-6 years ago, 7 years ago. I was on the FTC side where you had 2 behemoth health systems that wanted to come together. And, like they were both pretty high quality. If they weren't, they could get there on their own. Like there was just no logic here beyond they would have a very, substantial amount of market power. I think things like that you have to look at and say, you got to really prove why you think this is a good idea. The instance you have, and again, without looking at the specifics of the case, seem much more reasonable to me that you can improve quality. Look, sometimes improving quality can increase costs. That's not necessarily a terrible thing. Obviously, how much cost increase, how much quality benefit. But at the end of the day, the goal is can you make healthcare meaningfully better, and can you do it in a way that's not exorbitantly expensive? I think there are instances where that can happen with consolidation, with purchases, with acquisitions.
Right. You mentioned the movement, which has been just around the corner for the last 30 years to value-based payment and risk.
Any day now, Bob. It's just about to happen.
Coming. Just hold on.
Yeah.
One of the more surprising changes in the market for healthcare has been the growth in Medicare Advantage.
Yeah.
From a pure fee-for-service system to now, I guess about half of Medicare patients are in some sort of different kind of arrangement. So tell us what your take on the Medicare Advantage transition has been. And of course, now there's a fair amount of pushback. You know, that it was made to be generous so the patients and providers would go into it. And now there's a fair amount of pushback that it's too generous and it's milking the system and all of that. So talk a little bit about the backlash against it as well.
Yeah, I think this is a really interesting story because after the ACA was passed, I can't remember the exact number. I want to say at that point, maybe 20% of Medicare patients were in MA, somewhere in that range. Maybe it was 15, maybe it was 25, but it was sort of in that range. It is now over 50, it's like 52, 53%. I think there was some early data, including one paper that I published. There were other things that like Kate Baker and others published that suggested that the early days of growth of MA actually had a beneficial effect on traditional Medicare. It had a dampening effect on spending in the traditional Medicare program because a lot of the early MA programs that expanded were managed care. They were doing a better job of managing quantity. Obviously, there were spillovers. If you got doctors to practice a little bit more efficiently on the MA side, they tended to practice a little more efficiently on their Medicare fee-for-service side. So I think there was a nice story to be told. I would say through about 2013, 2014. It is a very different landscape now. About a month ago, I landed in Miami one night for this biosecurity conference I was going to, and I got off the airport and was waiting for an Uber, and a bus drove by advertising an MA plan, and it said $200 a month to you for your grocery bills. And I was like, that's a nice benefit. I'll take $200 for, I'm not part of Medicare, but my point is, like, it is clearly too generous. And what has happened, and there's a bunch of technical reasons, the way that they're doing star ratings and what has led to these massive bonuses. David Myers here at Brown has actually been doing some of the best work on this to really lay out how it is that we're overpaying. A lot of the payments are driven by your local Medicare fee-for-service costs. And what has happened, and you can see the logic of that, but what has happened is the healthy patients all get siphoned off to MA. The Medicare fee-for-service population that's left is sicker. Their spending goes up. Medicare Advantage reimbursements go up because of that. That generates the incentive to pull more of the healthy people that are still left. And we get into this almost of a death spiral of Medicare fee-for-service. So it's a huge problem. And we are, there are different estimates, but we are clearly overpaying tens of billions of dollars. And there's a bunch of policy things you can do to try to unwind this a little bit. But it is not, I think, where we want to be. And some of the backlash has become that, there are things people liked about practicing in a Medicare fee-for-service world. Like you didn't have to like justify every MRI and CAT scan. Now that we could talk about whether there were too many MRIs and CAT scans, but that was certainly something doctors enjoyed. Prior authorization has become a huge problem in general, but particularly in the MA plans. And so the backlash is real. I think we don't have to get into like MA is private insurance and therefore bad, as a lot of people on the left like to say, or MA is private insurance and therefore good on the people on the right. Like, I don't think that's that helpful framing. There's good behavior, bad behavior. We got to go after bad behavior. And we've got to not have policies that create distorted incentives to drive MA up, when what we really should be doing is just making sure people are getting the coverage they need and the quality that's good.
Yeah, it's hard. I mean, in some ways, the retrospectoscope is always 2020. It felt like you had to be generous in order to get people in. It also felt like the prior auth thing and the conflict between the payer and the provider is almost feature, not bug. It's going to emerge in a system where there's a fixed amount of money allocated to provide care for elderly people who are going to need some care. So how do you think about this conceptually? Like, what could we do to get this right?
Yeah. So part of the problem on prior authorization has been, I mean, look, I agree that like private insurance has always had some amount of prior authorization. It has just really exploded. The number of things you have to do for that now require prior authorization has gone way up. The hoops you have to jump through, as you know better than most people, a lot of private insurance companies are using AI systems to sort of do this, and it's not very elegant. My favorite part is now a lot of doctors are using AI to respond. So it's like my AI will fight your AI, and whoever has the better AI will win. So there's a little bit of like there is a prior authorization has a role. It can make sense. It has gone off the deep end. I think that's kind of one part of it.
Mhm.
The generous payment stuff, because of the way that the policies were set up, have essentially created this spiral where fee for service is becoming harder and harder to sustain. It'll always just because, and there are communities where 80%, 90% of people are in MA. And if you think about who's in fee for service, they're the sickest, most complicated patients. And by the way, pretty good data that when people get really sick in MA, they drop out and go to fee for service. That's not good for the system. So there are policy tweaks that can be made to try to stem some of this. My sense is MA is going to be a part of the Medicare landscape, probably forever, but certainly for a long time. That's fine. It's just we should not have policies that are making these distortions worse, and that's what we have.
Would the world be a better place if everybody was in MA?
MA is constructed today, probably not. I'd worry about people who are really sick. But if you could put in the right guardrails, I don't personally have like a strong ideological bent on this. Like I think if you could set up the right set of incentives and not do some, and put in the right guardrails, that'd be fine. I also think Medicare fee for service is a good system. The last point I'll make on this, though, is, what's interesting about America, right, is when I do international comparisons of looking at health systems, is a feature bug, depending on who you are, of American healthcare is that we got everything. You want single payer, we got that. You want private insurance, we got that. You want a low, cost payments provide whatever, we got that in Medicaid. So it's always going to be a hybrid and a mix of stuff. And I don't know that we'll ever get to an MA for all, or an MA for all people in Medicare. I think Medicare fee for service will always have a role. Policy's just got to be about trying to keep the stuff from like blowing up, getting out of control, or harming patients.
Mm-hmm. Let's talk for a second about drugs, and I guess I'm particularly interested. Let's talk about drugs that actually work but provide marginal benefits at crazy high costs. A new Alzheimer's drug, maybe it does work and slows down the progression of Alzheimer's by 6 months or a year and costs a quarter of $250,000, or a new immunotherapy that expands life expectancy by several months, but costs $500,000. How does a system like ours think through those trade-offs?
Yeah. I'm gonna answer this in a second. I was gonna say, almost the harder question is what happens when those drugs are like $3 million and work really well. Different problem.
Yeah,
which
right.
we can talk about as well. Look, I think the issue is, and I think the strategy so far from payers has been to say, if we have a marginal benefit, the on average benefit is 6 months. Do we think that everybody benefits about 6 months, or do we think there's some people who benefit 5 years and other people who benefit 1 month? And can we figure out who the 5 years people are and pay for that? And then there are some new payment models that people are working on developing where they say, we'll pay you more if it's a 5-year benefit and very little if it ends up being a 1-month benefit. It's hard to figure out how to like implement that. But that's what I think people are trying to get to, because for the small proportion of people who do have massive benefit, you do want to pay for that. For something like Alzheimer's. You can extend somebody's cognitive functioning and life expectancy by 3-5 years. That's massive. But if you're only doing it for 10% of population, you don't want to pay for everybody. So I think that is really hard work. I haven't seen it work in practice, but that is, I think, the goal that policymakers are trying to drive to and payers are thinking about. I'll just go ahead on the other question about curative gene therapies that are going to cost $3 million. We have got to find a way to pay for it for everybody who's going to benefit.
Mm-hmm.
The problem is, if you're Medicaid and you have I don't know how many people with sickle cell there are in America, let's say 100,000, it could be the right number. $3 million for a sickle cell treatment for $100,000. I'm sorry, 100,000 people, that's $300 billion. That's just not going to happen. Medicaid can't afford that. But denying people life-saving, life-altering treatments like that is also not acceptable. So I think we're at a point where we are going to have to figure out solutions here. I think there are people who are working on new payment models, like essentially a subscription service kind of thing, or take that person with sickle cell disease, there's going to be a $50,000 payment a year for the rest of their lives. Whatever insurance they're in, Medicaid will pay $50,000 during the time they're in Medicaid. If they go into private insurance, that'll happen. Like, there's probably a way to do this that people are experimenting with, but it's a huge conundrum because we now have drugs that are incredibly expensive and incredibly effective.
Yeah.
And there's no way around finding a way to get people those drugs.
Yeah. And even the incentives that if you knew you were going to be in the same health plan forever, you could do the, all right, I'm going to spend 3 million now, but I'm going to be saving $200,000 a year of hospitalization costs forever, and it stays within my own pot of money. Whereas
Yes.
in the way our system works, there's no guarantee you'll still be in the same.
And in fact, pretty good reason to believe that 3 years from now, you'll be in a different insurance plan.
Yeah.
So why am I going to pay 3 million and then the guy 3 years from now benefits the most?
Yeah. We're both general internists. Tell me what you think of the state of primary care. I think most people look at the American healthcare system and look at a system that's super specialized, the primary care infrastructure, very small and weak compared to many other countries. And as our graduates look at a future career in primary care, they don't see a whole lot of happy doctors out there. So what do you think needs to be done to elevate primary care? And do you see any hope on the horizon that will be done?
Yeah. Can I push back on the premise of that question a little bit?
Of course. Here I am asking you all the hard questions. You haven't done anything to me. Go ahead.
All right. Well, so one of the surprises, I wrote this paper back in 2018, or what feels like a couple of centuries ago, with Irene Papanikolaou, where we did a comparison across all the high-income countries, OECD countries, on a bunch of different metrics. And to my shock, and we really did dig down to verify this, the proportion of doctors who are primary care versus specialists in the US is about average for the OECD countries.
Huh.
That was when she first showed me the table, I was like, no, this is just wrong.
Right.
And we did a lot of work to chase that down. And I'm happy at some point to talk about all the stuff we did, but I feel pretty good about that as a truism. So that's interesting. Second thing I will say is that that the primary care challenge is one that other countries very much feel as well. So when I've been in, certainly the UK, but they handle it differently. Everybody has a GP, but like people's ability to get in, short visits, don't feel like they get all the time they want with their
doctor
GP.
every time.
Different doctor every time.
Yeah.
All sorts of problems. And that's the NHS, which has actually been pretty focused on having a strong general practitioner network. And then once you get into like places like Germany and France and the Netherlands, it's all very, very different. And so I'm not sure that anybody has quite figured out primary care. That's point number one. Point number two is primary care is changing a lot in my mind. And part of it is like, what is primary care? So some of it is like chronic disease management. Some of it is care coordination. Some of it is managing urgent care issues. And I think increasingly we're seeing a fragmenting. Like you go to different parts. So primary care itself is getting fragmented. I guess my view on this has been, it's not clear to me that I can't believe I'm about to say this and I'm probably going to get shot by somebody, but I'm not sure everybody needs a primary care physician. A lot of older chronically ill people need a primary care physician. Mm-hmm. They need that continuity of relationship and that care coordinator. It almost surely needs to be done with a team, not a doc alone. And I think we're in the midst of trying new models. Like I see all these new primary care things that come on, and Amazon bought one and Walgreens and everybody else. I feel like we're in an experimentation phase where people are trying to figure out what the right next set of models are going to be. No one's figured it out, or at least not that I have seen. But in general, I see this as like a good thing. And the only other point I'll make on this is when I travel internationally, believe it or not, a lot of people in other countries look at America's innovation in the primary care space with some envy because they feel like they have a very static system that's not working and they don't really know how to innovate around it. So it's not a very satisfying answer, but I do think we're in a transition period. Maybe one last point, bipartisan, because we're going to go back to the election, bipartisan support for more primary care and community health centers in rural communities, that the sort of underserved population, how we make sure there's more availability. that has been a delightfully bipartisan strategy that I've been really pleased about.
Can you see a world where primary care doctors are paid better, which probably means a world where super specialists are paid less, assuming there's a relatively fixed amount of physician payment to go around?
Yeah, I mean, as you know, there's been a lot of talk about how we fix the physician fee schedule from Medicare. There have been some movements on this. In the past, has not been adjusted for inflation. How do we do that? And then really, how do we make cognitive specialties as lucrative or as almost as lucrative, or at least better compensated compared to technical ones? There's always talk of this. There's always discussion. I think it's been very hard from a policy point of view to move. I think to the extent that we're going to ever see movement on this, it's going to be more payments to primary care doctors without cutting specialists. I just don't see any world in which you're going to have significant cut to specialist pay to pay for more primary care. Just how we solve problems, we just throw more money at it.
Yeah, and figure out where it comes from. If folks have questions, put them in the Q&A. I have a couple more, and we've sort of talked around health technology, but it's time. You sort of mentioned that there needs to be a disruptive force. It feels like the most likely disruptive force is going to be AI. So tell us what your view of AI is, overhyped, or you think real deal, and how do you see it playing out in terms of disrupting the healthcare world? Then we'll kind of get onto the regulatory piece after that. But why don't you give your sort of high level view of where
of all the people who should be answering that question, Bob, it's you.
Yeah, eventually I will. Go ahead.
Because you've been thinking about this a lot. I've been thinking about AI in a couple of ways. I mean, first of all, I do think this is a space where just a lot is happening, a lot of innovation is happening. People always say not all innovation is good, not all innovation is progress, but that's fine. Do I think AI as a tool or as a technology is overhyped? I do not. I actually think it's pretty transformative. We just haven't largely figured out how to use it all that effectively. The analogy I use, you may have your own, is I think of this as like electricity. When electricity first showed up, people generally just electrified whatever mechanical process they had and got some benefit. But it took a little while for people to reimagine systems. That's a little bit of what's happening with AI right now. I think the big beneficiaries are going to be, if we can figure out how to deal with the regulatory stuff, is the large proportion of the world that doesn't really have access to high quality primary care physicians or doctors of any kind. I firmly believe that a community health worker with ChatGPT 4.0 is better at diagnosis and treatment than probably 90% of physicians in the world today. No, maybe they're not as good as like the great diagnostician. They're not going to be as good as Gurpreet Dhaliwal. I get that. But that's a high bar, and most people don't get to see Gurpreet unless he's opened up some internet-based practice that I don't know about. But the point is,
you're a veteran, right?
Yes, exactly. Well, because that's right, he's at the VA. But the point is, so we're gonna see, I think, an expansion of access. The biggest barrier of that is going to be regulatory, because doctors groups are going to fight back hard and say that's, it's not safe. But the truth is, I think we're going to see demonstrations of that. For physicians who practice at UCSF, I see it as much more of an aid. There will be all sorts of technologies that'll make you faster, better, make your life easier in terms of how you write notes. I mean, a lot of that stuff is already happening. Where it goes 5-10 years down the road is much harder to predict, because I think these systems are just going to keep getting better and better at a very rapid pace. Mm-hmm. And it raises all sorts of questions about how are we training our medical students and residents, and how are they learning to use these things. I will say this is a bit more about universities and health systems. I worry deeply that universities like the one I work in they do not appreciate how disruptive this is. And there's still a lot of talk about, are we going to let our students use AI? And I'm like, okay.
They're going to, whether you let them or not.
Yeah. And yeah, I have so many thoughts on that. I think most of which I'm telegraphing here. Yeah. So we have got to get our arms around this.
Yeah. You said something interesting, to many interesting things, but you said the regulation is going to happen because the doctor groups will fight back. So do you see the regulatory world being sort of linked to the guilds and the incumbents protecting themselves? Because there's obviously another view of regulation that got to protect patients because this stuff can go off the rails and somebody could die.
Yeah. So I think what I meant that primarily in the context of expanding access using AI-based tools, right? That the pushback, my line about a community health worker with ChatGPT is better than 90% of doctors in the world. Firmly believe that. And just maybe 90, maybe a too low a number. But the issue is, are you going to allow community health workers to do the kinds of things that, right? And that's hard because of regulation and that. So I mean, certainly for that. There's clearly a role for regulation. When I look at regulation in AI right now in the marketplace in the United States, from states, a lot of it is kind of not very sensical. Like, how do you use AI for prior authorization? Well, you have to have like a doctor also review it. I'm like, we're grappling with how to do this. I think there's a broader set of strategies coming out of the White House and elsewhere on like AI regulation more broadly on how do we not turn AI into things that cause a lot of danger to our society? How do you not use AI to build the next generation of bioweapons that are going to be extremely harmful? That stuff is absolutely essential. How effective those regulations will be, we can have a different conversation. But I do think that the standard regulatory stuff is going to try to push back on innovation that comes out of AI.
Yeah. Do you any thoughts about abortion rights and women's health? And obviously a huge issue in the upcoming election and huge health implications.
I will say that this was a topic that the vice president took on early after Roe. And again, I was at the White House when Roe fell under the Supreme Court ruling. And very quickly, she adopted this as the vice president, not as the next presidential nominee, but as the vice president, as sort of the spokesperson for the administration. So this is very much in her wheelhouse. And I think the Democrats believe, and I'm not a political analyst, but at least my very amateur read of it is that this has salience for people, certainly for women. So I think it is going to be important, which is why you see all this backtracking from Donald Trump about, no, I won't sign an abortion ban. No, it's got to be left to the states. I think it remains obviously a very divisive issue, but I think majority of Americans believe that some amount of abortion rights are important. That's what the polling says, and I think it's going to be important in how the Democrats turn out the vote.
Mm-hmm. One question came in. We have a lot of public health and private sector data that could meaningfully affect our policies and predictions. Do you have insights into how the results of the election could affect the use of these data, which are largely segregated to inform health policies? In terms of sort of the kinds of data, and I think what we've seen, data being manipulated in various ways that serve a political agenda. I guess the CDC is an example of that, as we think about the data that CDC had during COVID. Any thoughts about that, sort of concerns or opportunities around data use based on the election?
Well, I don't know if this gets at the question, but let me start by saying I think one of the good things that came out of the pandemic, a lot of bad things, but some good things. One of the good things that came out was the enormous amount of sort of what I think of as non-traditional data and the ability to use non-traditional data for public health and other things, right? And I'm obviously thinking about back to the 2020, Google Mobility, Open Table Reservations. There was all these sort of unique data sources that actually were very helpful. Some of that has gone away, but I do think more and more of that data has kind of gotten into the health system. Health systems are using more of it. And I think of that as generally a good thing. And I don't see the election having a big impact on that unless you get into personally identifiable information. Then everybody gets much more anxious about that. But I'm not sure if that's exactly getting at the question that.
Yeah, not sure either. But one of the things you've worked very hard on in your career is quality and quality measurement. There was a theory of the case 20 or 30 years ago that we just needed more measures of quality, and patient safety, and if we had them, they would drive the system to improvement, either via transparency and competition, or maybe even payment. You get paid more if you're providing higher quality. I think there's a fair amount of looking back now and saying that was a good idea, but the measures kind of have gone off the rails, and the number of measures is onerous. where do you think the quality world is, and particularly vis-a-vis measurement?
Yeah, I think it needs a bit of a bit or more than a bit of a reboot. And I will say up front that I'm guilty of believing in that measurement enterprise as well, right?
Yeah.
And writing papers about it. It was interesting. I testified recently at the House Ways and Means Committee, and the Republicans were railing on MIPS, the Program for Ambulatory Providers. And I basically said, look, MIPS was bipartisan when the doc fix was kind of repealed and the SGR was repealed, and it was broad-based bipartisan belief that like we should be doing more measurement. MIPS has largely been a failure. It's a lot of administrative work and no evidence that it's improving quality at all. So, so what does that all mean? Well, when I say the system needs a reboot, I think things that clearly didn't work. We have way too many measures. A lot of it was nonsense. A lot of it was very gameable. But I'm about to say something that feels like I've been saying it for 10 years, and maybe it's just a mantra and not really anything intellectually interesting, which is a bunch of us have been saying for a while, like we need fewer measures, better measures, less gameable, more focus on outcomes. Okay, that sounds great. How do we do that? And I don't know, like we've got to make that, because the alternative is no measurement at all. And I think that doesn't work. Like we have, if we have 20 years of over measurement being a problem, we have like 60 years of no measurement at all being a bigger problem.
Right.
So we have got to come up with something in between. And I'm hoping technology helps. I'm hoping that more patient-reported outcomes are important. I'm hoping that we finally get better at risk adjustment with all the new information that we have in our IT systems. I do think there is still promise here, but it can't just be trot out the old measures and see if we can do any better with them.
Oh, do you think that's the direction, that now all the data are digital, now that there's fancy AI to go into the digital, that the measurement of whether I or UCSF provides good care will be more looking at my outcomes with appropriate adjustment for how sick my people are?
That's what I would like to see. And that's got to incorporate not just what you did as a doctor, but what do I perceive as a patient, and gets into a lot of complexity of doing all that well. Yeah, I mean, I guess I still believe that like we've got to do more of that. But if the hypothesis that I'm basically putting forward, and it's a hypothesis, I don't have evidence for this, is that we need to do better on this, not abandon the enterprise altogether. And better means smaller, more focused, and more high value measures. Yeah. But, do I have a lot of evidence that that's going to be the panacea? No, but I think we've got to try.
Maybe last question, if your kid, and this is back off health policy and onto the larger questions, if your kid's asked, should I become a doctor, Dad, what would you tell them?
I would say absolutely. I mean, I love being a doctor. I don't feel like I'm a doctor enough. I just did a 2-week stint at the Providence VA, and I don't think there's anything I do that makes me happier. By the end of 2 weeks, it's hard because like the rest of my life freezes for 2 weeks, and then everybody's like, "Where have you been?" And so it's complicated, but it is incredibly joyous, and in a way that nothing else I do is. So yeah, I don't think any of my kids have any interest in going into medicine, but if somehow something happened where one of them got even the slightest bit of inkling for it, I would say absolutely.
Right. And actually, one last question. If the election goes certain ways, would you be up for a job in the administration?
You had to end with that, didn't you? Here's how I think about this. Serving the country is, I mean, the chance to serve when I did was by far the most meaningful experience of my professional life. It was just an extraordinary experience. And one of the things I say to people is when you have a chance to serve, you should serve. It's hard. You get beaten up. You work crazy hours. You get paid like crap. Other than that, it's great. It is great. It is absolutely extraordinary experience. And the reason I said yes, I had to say yes when the president asked, but also because I felt that they convinced me that I had something useful to offer at that moment. And I think, that if the president of the United States, whoever that he or she is, ever calls and says there's something I have to offer to our country, it's going to be very hard to say no.
Perfect answer. Ashish, thank you for spending the hour with us. Thank you for your service. We are very proud of everything you've done and will do in the future. And it's a very interesting time in the world in general and the world of health policy specifically. And thank you for elucidating it for us. Really appreciate it.
My pleasure. Thanks for having me back.